today. My name is Afifa Rahman Shepherd. I joined the Swee Hock School of Public Health almost 2 years ago now to start a PhD on regionalizing the governance and technical capacities for pandemic preparedness and response. So it is a real delight for me to MC this event, bringing together an exceptional panel of experts to challenge our current thinking in global health and drive us towards more equitable solutions for the future. Before we get on with the exciting event, I'd like to just raise some housekeeping issues. Please ensure your mobile phones are set to silent and refrain from consuming any food inside this seminar room. Please do note that we will be conducting photography throughout this event, and the session is currently being video recorded. Please note that mask wearing is optional, but strongly encouraged if you are feeling unwell at all. Next, in the case of a fire or emergency, please do not rush down the staircase as the steps are a little bit narrow here. Do not leave your valuables unattended. Please do keep calm. Do take note of where the exit points are at the front of the seminar room, and please follow the escape route, which is currently shown on the screen. You will be following our ushers in an orderly manner and assemble at the multipurpose field, which is generally in this direction. For guests who would like to connect to the NUS Wi-Fi, please follow these steps and feel free to take a photo in case you need to refer to it later on. With that, distinguished guests, colleagues, and friends, a very good afternoon and welcome to the Public Health Thought Leadership Dialogue presented by the Swee Hock School of Public Health. In the aftermath of the COVID-19 pandemic, it has become increasingly evident that achieving health security is intricately linked to the pursuit of health equity. The landscape of global health is evolving. It's demanding a departure from conventional aid paradigms. Health as a common good at the national, regional, and global levels necessitates a shift in our perspective. The imperative for stronger national and regional capacities prompts a critical reassessment of our global agenda. How can we reformulate our approach to global health in light of these pressing realities? And as we confront the challenges posed by global health threats, what are the innovative multilateral systems and collaborative strategies that we can envision that are distinct from these historical models? With that, we are delighted to have with us today our guest speaker, advisor, advocate, activist, and former Swedish Ambassador for Global Health, Dr. Anders Nordström, as well as our panel of distinguished experts to discuss advancing global health for more equitable health outcomes and health security for all. I would now like to invite the Vice Dean for Global Health at the Swee Hock School of Public Health, Professor Hsu Li Yang, on stage to introduce our distinguished speaker for today's session. Prof Yang, please.
Thanks very much, Afifa. We're going to be informal today because Professor Ivy Ng tells me if I call her Professor Ng, I have to pay $5 to the President's charity. So
don't try to call me ambassador.
So colleagues and distinguished guests, it's my pleasure to welcome you to the 13th edition of the Public Health Thought Leadership Dialogue. And because it's Chinese New Year, 13 is not an unlucky number. The PHTLD focuses on major issues that impact local and international populations. And as mentioned by Afifa, today's topic is advancing global health for more equitable health outcomes and health security for all. Now, global health has its roots in tropical medicine, which originated from the need to maintain the health of European and British colonizers and their colonized populations. And this subsequently evolved to the concept of international health, with the application of public health principles to low and middle income country problems. And the term international health is somewhat loosely defined, but it's commonly framed as international cooperation in health that is often linked to trade and security, with high income countries and organizations and individuals providing direct healthcare and health system development in a lower income country. Our current concept of global health places a priority on improving health and achieving equity in health for all, with a focus on interdisciplinary collaborative solutions to transnational problems. So when we conflate this with the concepts of health security, which primarily focuses on safeguarding populations and national interests from health threats such as pandemics and bioterrorism, sometimes you can create prioritization conflicts and paradoxes in policy crafting and decision making. and not to mention all the academics like me who are uncomfortable with the two terms being bandied and boxed together, and who might view it as a throwback to the archaic ideas of international health. But of course, we live in a real world and not in an academic ivory tower. And today we are honored to have a very eminent visitor who has lived and worked through the application of both these concepts to help light the way forward. Anders is a medical doctor with a long, varied, and illustrious career in public and global health. He's got a Wikipedia page to himself, which is very colorful in terms of the work he's done and his experience. And I thought I'll just highlight a few of this. He was the interim executive director and one of the key architects responsible for operationalizing the Global Fund to fight AIDS, tuberculosis, and malaria in 2002. He was appointed Assistant Director General for General Management at the World Health Organization, and he stepped up to be the Acting Director General of WHO between May 2006 and January 2007, following the sudden death of the then DG, Dr. Lee Jong-wook. Between 2008 and 2010, he served as Director General for the Swedish International Agency for Development Cooperation, SIDA, following which he was appointed Sweden's first Global Health Ambassador in 2012. And in 2020, he was appointed to lead the secretariats for the Independence Panel for Pandemic Preparedness and Response, chaired by former New Zealand Prime Minister Helen Clark and former Liberia President Ellen Johnson Sirleaf. So please join me in welcoming Anders to deliver his address.
For some reasons, when you go back to my sort of history, I feel quite old. A pleasure being here. I was really excited about this invitation, and especially also to speak about this topic, because for me there are at least 3 or 4 dimensions into this. One is how we advance our thinking and perception and actions around global health. It's a concept we were speaking about that at the conference in Bangkok now, quite challenged. So I would speak about it with my perspective in terms of where we need to go. Then we have the word health. And we have spent, me and Sandra, who's here from Melbourne in Australia, quite a lot of time now also debating what do we mean by health and what is people's understanding of health. I will spend a bit of time on that. The second one is then this: is there a conflict between equity and security? And again, I will try to illustrate that first by talking about a couple of perspectives on health and how equity and security comes into those. Then I will give just two examples of the findings from the independent panel that again illustrates the security dimension and the equity dimension. And I will look back a little bit historically on a couple of examples, and then I will say a couple of words about what are trends in societies that all of you are aware about, but just sort of possibly making you to think about that those trends will also affect equity and security for health. And then I will finish speaking a little bit about my passion today, which is politics. I'm not a politician, I will never be become a politician, but I'm intrigued by how important it is for us as health professionals to understand politics, how to navigate, to understand the rationale of politics. So I will end with that. But starting then, health, equity and security. So I will use 4 slides here to illustrate some different kind of ways of thinking. And I suppose the most obvious here is then to think about health as a threat, the virus. This was basically paralyzing the world for almost 3 years. So health is this health. Killing the virus, stopping the virus, getting the vaccines. When we did the independent panel, we had a conversation in between Prime Minister Clark and President Sirleaf Johnson with the head of IMF. We thought we were going to speak about economic development, what are we going to do later, transition, building back better. No, it's only about vaccines. When are we getting the vaccines? So the focus then, health. And of course, and I will get back to this, this also illustrates extremely well this tension in between equity and security. So this is one perspective. Another perspective, all of those 4 are round for some reasons. So this makes a round symbol. Universal health coverage. This came from, or sort of consolidated at a high-level meeting in New York. People agreeing to what is the concept of universal health coverage. And universal health coverage is, of course, also equity and security. This is access to service. Everybody's equal right and opportunity to have access to good quality service. That is security. So security is not just your political security, it's also your security to be able to have access to health service. So that's a security dimension. And of course, then UHC itself That's an equity agenda. When we had that meeting in New York, the only one that spoke about how are we going to finance this from an equity point of view was Dr. Vernon Lee from Norway. She said that the best way of achieving UHC when it comes to financing is to have progressive taxes. So that's another way of thinking around health. Either it's a virus, to a threat, or it's about getting health service to everyone. The third way of thinking about this is to look at what we have, and you have the SDGs on you. We have a new development agenda with 17 interrelated goals. You can't achieve one without the others, they're all interrelated. And we have a health goal then, which is about maximizing health and life expectancy. This goal is about ensuring that you can live more and longer and healthier lives. So this is about health. You see the difference in between health service and health? So here you can think about the virus, you can think about health service, or you can think about health. Because if we're going to achieve that people are actually then living longer and healthier lives, and why we are doing that, of course, we need to look beyond the health sector. I mean, one of my colleagues in the foreign minister where I was working before, he gave me a piece of research saying that only 11% of the impact on people's health is coming from health service. Apologizing for everybody working there, that's also important, but there are factors beyond the health sector that are also, of course, influencing people's health. So that's a third way of looking at health. And of course, those risk factors, whether you are obese, what food you are having access to, I mean, there's a big equity issue here. People think that obesity is only because you're rich and you're eating too much. Of course, that's totally wrong. The lower socioeconomic groups are the ones most at risk. In Sweden, in the US, in South Africa, in very many Asian countries as well. So there is a clear dimension here also of equity. The last one is this. What is good for the planet is also good for our health. And what is good for our health, if we think about the last one, is also good for the planet. And here, of course, what we see today in terms of climate threat, big security issues. This is about our existence and basically our survival. That's what we are fighting right now when it comes to climate change. But that is so also linked to how that is affecting people's health. And not primarily only because of what we see in terms of global warming or floods. It's more that we are having changes in society that I will speak about in terms of the explosion of entities based on those risk factors. And those risk factors are, I would say, not 100%, but 80% associated with the same bad behaviors that we have for destroying our planet from a climate perspective. So this has also very much to do with both security, but of course equity. Because some of the reasons why we are still continuing to cutting down our rainforest is that people can't afford anything else. They are depending on this. Some. Then there are multinational companies that are influencing that as well. But there's clearly an equity dimension also why we see the development, or why we have what we have at hand here. So those are just four perspectives to think about health. Not one of them are right, of course, but I think it's useful to have all four perspectives. Health is not only about the virus. Health is not only about service. Health is a lot about health promotion and making sure that we can live healthy and not just surviving. And health is also clearly linked to the health of our planet. As a background, and to illustrate a little bit health, equity, and security. Let me then spend a couple of minutes then on the COVID-19, because as I said, this is possibly the most telling story. It's a very unrespectful word, but still, in terms of how we live through both the global health threats, major security dimensions of this, also triggering, if we look at the international system, a strong move now to move into global health security as the driving force. But it also triggered an enormous drive, but also political debate and tension around equity. Who has access and who has not? So the big issues, of course, as everybody are aware about, were the vaccines. Who had access to the vaccine and who did not get access to the vaccines? And of course, a vaccine is also about security. You are safe if you are being vaccinated, at least for a while. So I was working, as was said, with former Prime Minister Helen Clark and former President Elizabeth Johnson with this panel, 11 fantastic people. And we spent 9 months early during this pandemic. But still, I think when I go back now and look at our analysis and recommendations, they are still valid. Now I'm only going to take 2 examples of what came out of what we did. And the first one is about the security part of this. I mean, we went into detail to see what actually happened during the first hours or days of the pandemic. Christmas, Wuhan, when did China report the Wuhan authorities, when did WHO act, etc., etc. And basically, we found that time was lost at three stages. And all of this led us to then hear the conclusion that what the world needs is both not just a better and quicker and more efficient alarm system, but also an alarm system that people understand. And I'm going to tell you why. I think you remember those days. But what is interesting here is that here, first cases reported, IHR's obligation you should report within 24 hours, it was reported within 48 hours, so late, but not so late. WHO notified the world on the 5th of January, but then things begin to slow down. So the Emergency Committee of IHR, of International Health Regulations, they met on the 22nd and 23rd of January, couldn't agree whether to declare this as a pandemic or a public health emergency of international concern. Partly because of China was there, and I don't think they wanted that at that stage. So they recommended the Director General then not to do that, because they didn't know yet. And you should also be aware that that international system was changed because of geopolitical reasons before the Director General had more authority before 2005. So when Dr. Brundtland was handling the SARS pandemic, remember he told people in the world, don't go to Canada. And that created a lot of international tension at that time. But this time, the Director General didn't dare to do anything else than following the advice of the Emergency Committee. They changed their minds a week later on the 30th of January and said, this is a public health emergency of international concern. So that was a little bit of delay, but that was not the big problem. The big problem was what's happening between here and here. In most countries, not in all countries. If you take South Korea, Singapore, Taiwan, etc., a lot happened because you had experience from SARS. So you took measures. But if I take my country, we didn't do much. We thought it was going to be like an influenza, a few cases, this is far away, we basically did not. And we relied on our very, very sophisticated and strong health system. It didn't work. And that was the case for most countries, especially in Europe. Then you had a few cases, countries like the US, who took a very bad sort of course, approach to it and say basically, this does not exist, we will do nothing, we will not engage. They were the outliers, the US and the Brazils. But most countries basically lost February. So it was not until early March, both when the hospital began to fill up in Sweden, because of people coming back from Italy, where they have been skiing, and Italy had had more outbreaks, cases than what we have had, but also 11th of March, what happened on the 11th of March? Anyone knows? This has to do with communication. The Director General of WHO says this is a pandemic. The world did not understand what the fake was, but they understood what the pandemic was. So in some way, this illustrates that the system was too slow, WHO did not have the authority, plus the alarm bell, people did not understand what the alarm bell actually meant, except for some countries. So that was one dimension that we brought up that has to do with the more of the security aspect, of course, and this is something that the world is now trying to address. We published all the details, exactly what happened in an article in the Lancet. The other part was, of course, the inequalities. And before just saying 2 words about the vaccines, because all of you know that, but there were other aspects of inequalities here as well. One, of course, was people's access to health service if they fall sick. I mean, we are living in both in Sweden and Singapore and countries where everybody have access to health service. That's not the case in many countries. So, I mean, if you didn't have your health insurance, you were in a bad situation. But another dimension is also, if you think beyond health, in Sweden, if you are sick, you can stay home and you have an insurance, so you will have your salary paid. That is not the case in many countries. So many people actually went to work, even if they were sick. That's another equity and security dimension of pandemic. Vaccines were developed. You've never developed vaccines so quickly as we did this time. I mean, in some way, the problem with equity was that in some way the vaccine industry was too successful. We got too much. And because of we didn't know what was going to work, both the European countries and the US and Canada, they basically had taken the monopoly of all contracts. They had contracted all vaccine producers to be on the safe side, meaning that Europe, we had 5 times as much vaccines as we needed, because we didn't know what was going to work, but they were very successful. And then we were sitting there with 5 times as much vaccines, and then we came into the big issue. Why are we then starting only with our own population and not making sure that all people in the world are getting, or the people that are most prioritized are getting access to the vaccines? So that was basically the big equity issue here. And that today, I would say, has enormous side effects now on the geopolitics. I mean, why we are not coming to an agreement on the pandemic accord in Geneva is not so much about the substance. It's about the legacy of this. The African Union vis-a-vis the European Union. The African Union being still extremely unhappy with the way that African countries were treated. And as long as you don't rebuild that trust, they will never be able to make any progress. So it's, in some way, the equity issues has really now come to at the top of the agenda and really make it clear. And also countries, especially I would say the African countries, but also some other low and middle income countries, are now quite vocal about this. I'm going to just go back to, I'm coming to 2 other examples in a minute. We presented our report 9 months after we had started with some clear recommendations, including on the pandemic treaty. And we made a reference to what happened in Russia with the Chernobyl in 1986. That big accident when the nuclear plant collapsed happened on, if I remember right, 28th of April. 6 months later, there was an agreed sign-off new convention to inform the world in terms of the spread of nuclear risks. 6 months. And Helen used that as an example to say, we have a Chernobyl moment now, we need to act quickly. Now, we came with a report. 2 years later, we're coming with a report now in May. 4 years later, nothing has been implemented. Nothing, basically. So the world, I would say, is more at risk now than when the pandemic started, mainly because, again, the geopolitical situation we have right now. But some of those simple things, a better alarm system, an agreement on a platform for how you're going to share both the genetic, etc., sequence with industry, etc., and getting better access. Just getting the money. It's not big money that is needed. Nothing. Or very, very little. So, where we started the work with the panel was basically to review 16 previous commissions. And we found that those things had been suggested before, but not implemented. If we looked at the way that we are monitoring whether the world is prepared, and some of us are part now of the New Lancet Commission, looking at sort of what indicators should be used to see whether the world is prepared or not, the way that we monitor this in the past by the Joint External Evaluation, the GEE, or through the Global Health Security Index, basically said that the countries that were doing best, they are the ones that did worse. So the UK and the US here at the top. They did not do so well. So basically we got it wrong, either in terms of our indicators, or we had not been honest when we were actually monitoring their capacity. But it's not a good enough tool, and I think that's something we need to learn from. But the most important one is that the political will to take decisions is lacking. Just 3 to illustrate this a little bit to give you some perspectives on how we dealt with equity and security in the past. Because as somebody was sort of introducing me, now I'm getting old. Mid-90s, when I went to Zambia, there were no drugs or treatment for HIV, people were dying. Then in the late 90s, that stops. The Secretary General then, when activists are saying we can't let people die, we have drugs, but they are too expensive. And then at that time, the Secretary General of the UN, United Nations, Kofi Annan, he called the 6 big pharma and basically had a tough discussion whether the negotiation was under an umbrella called AAA. And then things began to happen. That negotiation to get the prices down, diverse prices to different countries, the political will, having a big high-level meeting in the UN, setting up new indicators, target and UNGA, and then the creation of the Global Fund, and a little bit before that also the creation of UNAIDS. Successful, if we look back now what has happened during the last many years. It's still an unfinished agenda, but the big challenge at that time, I remember the front page of Times saying that Africa is dying. In some way, the world actually managed this. And this, of course, had a lot to do with security and equity as well. The only difference I would say here is that this was treated as an issue that mainly for Africa, for low-income countries, even if, of course, the US and some other countries were affected, but it was mainly, and also the funding was an aid, development assistance agenda. Here as well, here we began to come more into the sort of global health security sort of, because the world was really afraid that we would get Ebola to spread across the world. But that was limited to 3 countries. And then, of course, those countries were heavily affected, not just by the disease, but by how this sort of affected the economies, and the countries were closed then. So, again, another example that we managed, but again, and the last one is just on polio also being, if we look back, again, something that were affected mainly people today at least, mainly people of lower socioeconomic groups. Again, here we are on our way actually to eradicate one dangerous thing in the same way as we did with smallpox once. So I mean, there are historical examples of where we actually have been able to actually manage different health threats. So the global trends, what is happening, what has happened. I would have loved to have this live. This is Anders Nordström's bubbles. Some of you have seen this live. This is then from, let me see what year now, 1990, that's right. Of course, here, equity. The difference in between countries in the world in terms of economies, but also in terms of health. Clear difference. And you've got Singapore up here. A bit annoying because you're further up here than where Sweden is. But what is interesting is if you look back 200 years. No. First, the spread, even if the log here is different, slightly different from the other, it's less spread here, so it's a different scale. But then we were actually a bit more advanced than Singapore. But that was then. But it's interesting to see that again, that we have a huge equity issue in the world, but on the same time, if you see where countries were then and where countries are today, there's been huge progress in the world. And this was always also what Hans was saying. Don't just see the negative, the challenges. There has been major improvement in the world as well, both when it comes to economy, wealth, and health. And again, here now Singapore is ahead of Sweden. And of course, big picture, you know that what we made big progress is on child mortality, maternal mortality, and as I showed on HIV, but also on even malaria. And the big challenge today is that we have an increased number now and prevalence of non-communicable diseases. So when we had the previous development agenda, the MDGs, then we had 20 million people dying from the 3 MDGs. So now we're down to 8 for that. But for non-communicable diseases today, we have more than twice as many people dying prematurely, 18 million. Is the global health community, you are studying that, are they speaking about NCDs today? Very, very few. That is the big health problem, and it's a poverty issue. It's an issue that affects poor people most. But still, the development community do not want to touch that because they are so loyal and affected to their own MDGs and to that money and to those institutions. So this is a big challenge, I think, for global health to move beyond the MDGs, to really move into what is affecting people's health of today, which the global health community is not doing. So if we're going to advance global health, this is my first message. We need to advance global health to address the real health issues, and that we are not doing yet in the global debate. And of course, what is affecting this, I'll go very quickly on this, is and we spoke a little bit about this morning, that also from both an equity and security perspective, we see the demographic changes happening in countries. This will affect also. We have now heavily sort of more aging populations, fertility rates going down. All of that will affect in terms of who's going to pay for it, and also what resources do we have in countries then vis-a-vis other countries. And again, Hans, we know what is going to happen in the whole world except for Africa. In Africa, roughly today, there are 1 billion people. Will there be 3 or 4? But the population growth demographics is an important factor here, of course, both on a national level, but also how this is going to impact power in the world. I saw some figures from China that the Chinese population is going to go down now from something more than 1 billion to 750 million in, I don't know whether it was 100 years or something. But still, it's going to change also the power balance, is at least my projection. Urbanization, of course, I mean, that is affecting people, gaps, disease outbreaks. I mean, we are, as I said, the planetary dimension of this, we're getting more and more into less of biodiversity. We're having more and more of zoonosis. So, I mean, the question is not whether we will have a new pandemic, whether we will have a new outbreak of a disease similar to what we have now. It's more, when is it going to happen? Tomorrow? Next year? 2 years? But it will happen. No question about that. Of course, and this you know as well. And again, here I think there are some hope in terms of how we look at one energy and climate agenda. There is some progress here. People are taking this serious and also making change now to move more into a fossil-free society, which also is good for people's health. Conflicts are rising. I'll go with that, I'll skip that. But then what I wanted to say also then, in terms of advancing global health. As I said, in the 90s and also now 2000, global health in some way is equivalent to development assistance and the development community. If we look at the financing, big picture in the world, I mean, most of the financing is coming from government resources or private resources in countries. It's tiny actually coming from external resources. So the ODA's share out of total financing in the world is of course tiny. If you look at low-income countries, it's bigger. It's only about 30% there. If you look at middle-income countries, about 3 to 4%. But there's still this perception that development assistance aid is going to solve and to finance all global health issues. And again, if you think back now about the pandemic, this pandemic was not about the poorest countries in the world. It was more about the high-income countries. So how should we think? And that goes back then to thinking around global health security. Is then global health security then dealing with the equity issue, the development issue? Or is this now, should we move into what we call then global public goods, global common goods, global public investments, meaning that we as government are investing in some sort of global insurance, investing in global common, again, goods, as people say, that we need to have in place. But that is for all in the interest of everyone. I mean, that was the idea from our panel, to say that there is a need now for more money, both for preparedness, but also have money ready when the next pandemic hits. But this should not be aid. This should be financed across the world by all countries according to ability to pay. No one is keen on that. Because all the rich countries today have aid budgets, and the Minister of Finance, they want you take care of this. We don't want to spend more money on this. So I think we as a health community have a bit of work to do here, and both looking a bit like a climate community that are making some headways here. But also, if you remember the big financial crisis in the world, then we establish a new sort of mechanism in the world to be able to tackle economic crisis, which is also a finance mechanism. Of course, it's not financed by aid. It's financed from the Minister of Finance directly. So this is, I think, the second shift here, that both the mindset to think that global health is equivalent, not just to the MDG agenda, but not to the old development agenda or the old development paradigm. And this should also, I think, have implication of the international structure for how we're dealing with global health. And what needs to come with this is, of course, that because of those resources are quite small, and what is most important is how resources are increasing in countries. And again, this kind of debate that is going on right now that the pandemic treated that, yes, global health security, etc., but you need to pay for it. I wrote a blog quite recently and said basically, I think there's some homework to do for some countries as well. Nigeria is quite a rich country. Where are you spending your money? What's your level of taxation? How do you let international companies to come in and to make good deals in terms of your resources? Who's getting that money? I mean, there is a link here in between also governance and also health. And I think in some way this debate about global health, and there's a lot of debate about colonization, that global health is a legacy of colonization and it's basically still global north suppressing global south. Yes, there is some truth in that, but I think we need a more sophisticated discussion, which has to do with also there is a responsibility here from different parts in the world. It's not just like now negotiating the pandemic treaty saying that, fine, we want it, we want equity, and you have to pay for it, we will do nothing. That is basically, if I take the African group, what they are saying right now, which I think is wrong. I mean, there is some movement on the African group to mobilize resources themselves, but the big picture is global health. We need to work together at the international level in a multilateral way, but on a different kind of health agenda, and also not limiting this to the development agenda. Development assistance is still usefully important to support countries that still do not have enough resources or in humanitarian situations, etc. But let's try to think beyond aid. And also the total sort of envelope then for development assistance, what I see happening among the OECD countries, the amount of money is decreasing. And what is going to happen this year when there's going to be replenishment for, I think, 3 or 4 of the big international organizations is going to be difficult, very difficult. So I don't think the future is here either. Okay, I'm finished about the politics of global health, which is my key topic of today. Equity or security, and how is, as you were saying in your introduction, how much is sort of the equity dimension then driving and playing an important role when it comes to the geopolitics or the politics of health, and how much is the security agenda doing this? And in some way, I can see 2 different constituencies here and ideologies, of course. But I think there's a lot of and especially if one could move on the thinking around global health beyond aid and looking at more from a global common interest from the SDG agenda, then I think there does not need necessarily to be a conflict in between the 2. Right now, as I said, we are in a mess. We are no, let me start like this instead. I'll get to the mess. Because there is something good as well. I mean, we have got health higher up at the political agendas. Again, looking back 30 years ago, when we had a high-level political meetings beyond the health people, we seldom saw health. And I'll show you an example of that. So when we had, these are the past presidencies, they have now moved on. But when India and Japan, this was the same time as Sweden has the presidency for the European Union, health was quite prominent. It was definitely on their agenda. Both of them were committed to actually make advancements. The question is then, what does those political declarations mean in practice? But still, there is a political interest and for health. And I suppose in some way, both good and bad, because with the interest comes also that the underlying political tensions will also influence that. Even if people have an agreement that health is important, but still coming to an agreement, it might be that they agree again on the substance, but they don't want to agree, basically, because of other political reasons. But basically, we see some progress. I'll tell you, how are we doing in time? We're doing fine. I've got 2 more minutes. A story in terms of the politics, and both about security and more security than equity, perhaps. This was in 2006. And as you were saying when you introduced me, then I was the acting director general for WHO. And WHO had negotiated that for the second time in history to be able to attend and to speak at the G8 meeting. The first time was in Japan, in Okinawa. And that was when Dr. Brundtland was there, and there was an agreement of then creating the Global Fund. That was a very important one. Then J.W. Lee passed away, and then I was then, okay, you go to St. Petersburg. So I was there somewhere, I'm here. Many years younger. What was interesting then, when I did the work with the independent panel, you can't read this in Swedish, then somebody sent me this and said that the most important agenda item at the G8 meeting is global health security. I totally forgot that was already at that time, 2006. Perhaps not so unexpected. My story here was also then, during this meeting, the Chinese president, no, not Chinese president, President Bush took me to the Chinese president during the coffee break. You've heard the story before. And then basically told the Chinese president that you better tell this help man, he's the help man for me. Yeah. He didn't know who I was, but he's the help man. Bush told the Chinese president, you better tell this help man if you have an outbreak of the disease next time. Because China had not then been reporting so well as they did this time from the SARS outbreak. So the US was very keen that China should be open and transparent, and then he was using me there so to tell him if you have an outbreak of the disease, because the US was very concerned about that. What I did, and this might be not so good today, but I brought in a bottle of Coca-Cola. And I had 3 minutes to speak, so I bought it up, but then empty Coke, and then an ampoule of Swee. And then my message to them was that, why are we reaching out with this and not this? And that has to do with, people's demand. And we've talked a lot today about health behavior, the nudging in terms of Coca-Cola, in terms of getting people actually to have an interest and wanting to drink the Coke, but also the logistics, the cold chain, the production. You can just think about the same when it comes to vaccines, and we are quite good at reaching out with vaccines today. But what was interesting then again in terms of messages, then again President Bush came to me and said, okay, I got your message. So today the negotiations goes on the pandemic treaty. Say a few words about this. My reflection, and we're starting a program in Stockholm now on diplomacy and politics for health, about how do you navigate in the political system. And there are a lot of training programs across the world today around global health diplomacy, but we're going to do something different. And it's sort of also learning from some of the processes that are ongoing now, that people believe first that the formal decision-making process, the board meetings, is where you take decisions. Of course, I don't think that's true in Singapore and in politics either. Informal, how you influence the decisions behind the doors before actually they are formally decided is much more important. So to do your legwork, to ensure that you have reached the right people, to be able then to have an agreement with them before you are into the formal negotiations or the formal board meeting, that was not done. This was not prepared. So people had not done the legwork, they just started, had an open box, everybody can come in with a suggestion what they want to have in the treaty. They didn't have a vision what should go in there. So that's the second part of what we're going to speak about in this program. It's about your vision. You need to have a vision, an idea, but then you need to have a flexible mind in terms of how you're going to get there. The third one, which is also missing in this, is about relationships and trust. And today, the whole process is totally lacking trust today. And they haven't invested in that. Instead, they're just fighting. The EU delegation, they just sort of continue with the argument saying, no, not accepted. This is a red line. This is a red line. Are they spending time instead taking a step back and saying, okay, we understand that we have a disagreement, but what's the issue? And can we at least give both sides something? Or how do you create relationships that will enable you to have that conversation that you actually know your enemy? Sandra knows my key approach to this has been dinner diplomacy, having had basically the whole world for dinner at home, creating my network. And that has been, it's a pleasure, I love cooking, but it's also been a very, very deliberate strategy to build my network. Today, I have access basically to quite a big crowd across the globe when it comes to global health. So that's the second part here in terms of politics. Politics is about informal decision making, it's about the trust, it's about the communication, the language. It's about also seeing the windows of opportunity and being able in some way to assess, is this now the new window of opportunity? Again, if I go back to HIV/AIDS, I was listening to Peter Piot, and what happened in the 90s, there was a window of opportunity there. Why could we create a global fund? And then suddenly, and this is the last one here, there was somebody who stepped up, a leader of some kind, who was prepared then to move. And of those kind of things that one should think about, or you could generation to think about how do you create your networks, etc., etc. The most difficult one is to create that brave leader who's prepared to step up, who dare to do it. But our program in Stockholm is going to be to speak about those competences. We're not going to teach about international system, we're not going to teach about health, but to talk in between themselves and with people that have been out in the international system in the past, and learning and getting some inspiration from them and some sort of mentoring support. So, in conclusion, why did I do that? Okay. But is that the one?
It's working now. It's working.
Now it's working. Some reflections. The world we have today, we have more similarities. You talked about tropical medicine. That was also how I was taught international global health when I went to medical school at Karolinska. Then it was tropical medicine. Today, the world is much more connected, and we have also more of similar issues. When the people at the Karolinska today ask for more research money to do global health, and the government is not keen, I say, if you should do global health research, I mean, you are doing it, but look across. You're doing research on diabetes. You're working with India, who's the most important research partner for the Karolinska today, because they've got huge cohorts for diabetes research. That is global health. Global health is no longer just tuberculosis. So we have more of similarities and more of connectivities, more opportunities, but there are of course more risks, as a lot of things are moving across nations. And then you were mentioning this about the regional and global. With now more regional capacities and national capacities, and that is happening across the world. We need to reformulate what we're doing at the global level. So instead of the global level both being a sort of a structure and governance that are basically trying to take responsibility, I don't think we need that any longer. But we need certain global functions. We need knowledge. We need to stimulate new research. We need to have an agreement on certain rules for how we behave or what we do, like international health regulations. And then the role of international financing, transfer of resources, I think is going to decrease over time. But to have negotiated deals with the vaccine industry and to negotiate them together, but possibly no longer at the global level like Gavi and the COVAX did this time, but at the regional level instead. So cooperation, but at a different kind than what we have today. So the present international system with organizations that are taking responsibility for implementation, my projection is that that should again begin to be phased out. And then the money side. And this is not just about money, it's also about the mindset. Because what comes with the development of the paradigm is also that we are helping you. So it's not just the money, but we are helping you, and from the other side, you need to give us the money. So this is a mindset shift, but also it's a shift when it comes to who's going to finance then global common goods is that. And then, don't forget in some way that those are political issues more than health issues. So even if we believe that we are doing brilliant in terms of public health evidence or medical evidence research, there is a reality and there's a logic and there's a science to politics as well. And I think we as health professionals, we need to bring that more into our competences, to use a political lens to understand how you navigate the political landscape. Because there is a rationale why political decisions are taken. Very often we say, you just don't get it. Wrong. Just listen to me, the expert. But there is another rationale for politicians. And I think we as non-politicians, we need to learn a bit more of that and applying a political lens on the situation we have. And then the silos here, and that's linked to also the shift here. Shift beyond MDGs to the real health issues, shift from ODA thinking and development thinking, and then the final shift is about also shifting from just the health sector to looking at sectors across, because that's health is not going to be achieved by health sector alone. Health sector is important, but not alone. So we need to shift. And if we then begin to use SDG 3, which is about maximizing healthy life expectancy, if we begin to measure and focus and try to implement that, and measuring the outcome, ultimate outcome, then we will need to work much more across across sectors. And then I think, bottom line, equity and security needs to come together. Thank you.
Thank you very much for that very illuminating discussion, even delving into kitchen politics and kitchen networks and dining. Yes. And now it's my pleasure to invite the other members of the panel up. We have Ivy Ng, who is the former Group Chief Executive Officer for SingHealth. She's been in that role for 12 years, just stepping down about a week ago, I think, and who has built SingHealth into the academic and clinical powerhouse that it is today. And it's under her watch that the SingHealth Duke Global Health Institute was established. We also have Vernon Lee, I think is well known to all of us. He is having multiple hats. He's the Executive Director of the National Center for Infectious Diseases, as well as Executive Director for the interim Communicable Disease Agency that is going to be stood up as the frontier, I guess, the agency that deals with all communicable disease outbreaks in Singapore. And then last but not least, we have Kiesha. Kiesha Prem is an infectious disease modeler who is on the WHO SAGE for immunizations. And she also leads the Lao PDR Public Health Office for the school, and health equity and other measures of equity are very important for her. So now we have the panel, and I'll have them speak a little bit before we open up to the floor, because I know all of you are dying to ask questions. Maybe we'll start with Ivy, because you did set up the SingHealth Duke Global Health Institute, and I wonder if what Anders has said resonated with you and your reasons for setting up SDGHI. And of course, he also talked about politics, which maybe you know better than many of us in the room, at least from Singapore.
Okay, thanks very much, Liang, and thank you, Anders. I thought that was very, very stimulating and covered all the main points. Yes, Liang's correct. We set up the SingHealth Duke and US Global Health Institute. So maybe I'll just share a bit about the thinking behind that. If nothing else, we've learned in the last 4 years that globalization isn't just what we think about, traveling and going to see new places, the easy access to different countries. It's also what affects any other country affects us. I'm here from the health service, so I'm downstream. Vernon's at the frontier. We're pretty much close to the frontier as well. But if I bring you back to 2020, you saw Anders' slide on how at that time it was called the Wuhan virus, right? So very distant from us, but actually not that distant, right? You think about it, anywhere in the world is just a couple of hours away from us. And I remember that as we watched it unfold in Wuhan, I called for a meeting. All the CEOs, CMBs in SingHealth, all the infectious disease experts, the COOs, the ops folks, everybody. And we had our first task force meeting. It's interesting, I was flipping in Outlook, and that was the 21st of January, 2020. Our first task force meeting. It was called the Wuhan Virus Task Force Meeting, right? And the 23rd of January, SGH saw Singapore's first case of the Wuhan virus, all right? And we handled it really well. We had in place all the screening questions, the isolation. None of the patients that were in our very crowded SGH ED were exposed. And that's because we had a 2-day head start. We said, let's again not say if it comes to Singapore, but when. I admit, I was chairing that meeting. I didn't think it would be 2 days later. But I thank the team because they were fantastic. Straight after our meeting, they put everything in place, the barricades, the screening, everything. 23rd, we were tested. And, you know, today, we are 3 days from Chinese New Year, right? 2 days from the Eve. And actually on the 23rd of January 2020, we were 2 days away from Chinese New Year. So you said, when will disease X come? Who knows? Who knows? We didn't know when COVID hit us. We didn't know when it would come, but we knew it would come. And it came 2 days before Chinese New Year. And I remember I had said we'll have the first Wuhan virus task force meeting before Chinese New Year. So we'll have a quiet Chinese New Year. But by the 23rd evening, I was alerted that there was a patient, the first patient in Singapore. By the way, we screened his family and, you know, the son had it and so on. And we had our second task force meeting on the 23rd and on the eve of Chinese New Year on the 24th, right? Because we knew it would escalate like this, which it did. Because as we did the contact tracing and all, we picked up more cases, right? So I just wanted to say, global health is right here. And whether we proactively recognize it and take the bull by the horns and proactively address the issues before they become big problems for us is the question. So you need to do it. So COVID taught us that. I wanted to say when I saw Anders, that graph, and Singapore is way up there. I don't know how the rest of you felt, but I felt somewhat embarrassed, frankly. I mean, I think, yes, we have a lot to be proud of. But if you are up there, then you need to do stuff to bring everybody where we are. And so my second point is it's a moral imperative that if you have reached that level of, healthcare, then it behooves us to do something to ensure, there's greater health equity, because it will come back and reflect on the health in Singapore as well. You can't just, be the ostrich with the head in the sand and say, we're doing okay, let's not try to muddy the waters. And then I wanted to say, it's not just that we want to help others. Actually, we benefit tremendously from global health. What do I mean? I think any academic medical center needs to be a learning system, constantly learning. And there's so much that we need to learn from the countries around us. It feeds back to us. It feeds back to the quality of healthcare that we deliver here in Singapore. It feeds back to the health outcomes that we continue to pursue. We got to do better. Well, let me give some examples. Frugal innovation. Very hard to excite people about frugal innovation. I know our healthcare budget is strained, and we are trying to cut down costs and all that. But we are an expensive health system. We have access to most expensive investigations, therapies, etc. And I think when we go out there, we learn how to do things better in a sustainable way. And then we bring it back. So frugal innovation, we learned that. I wanted to say, even in high-end research, and I'll give you one example. We have a researcher, cancer researcher actually, Prof Bin Tian. He has collaborators in Taiwan, and they said to him, we have very high rates of kidney cancer. Couldn't figure out why. So he went there, did a collaborative study with Chang'e. They did the molecular signatures of the kidney cancer there. They went into the epidemiology. They found that there was a high utilization of this herbal supplement. So they studied the herbal supplement, and they found that there was a carcinogen, and it created a molecular signature. And when they tested the cancers in Taiwan, kidney and liver cancers, 80% of the cancers had that molecular signature with a positive history of taking this herbal carcinogen. Expanded the study to China. From 80% of the cancers, it dropped to about 60% of the cancers had the same molecular signature. Southeast Asia, 30%. And I have to say, that besides, yielding to landmark papers in Science Translational Medicine, that's nice from the academic viewpoint. But the question is, what do you do about it in Singapore? And it opened our eyes to the fact that we haven't, taken all this that we know about molecular genetics, genomes, and all that. But have we taken it to look at the plants that are basis of medications, that, by the way, a whole lot of our patients take herbal supplements with no evidence and no data. So that stimulated us to launch the SingHealth Duke NUS Biodiversity Medicine Institute. And just 2 weeks ago, I opened and launched our genome garden, okay, right in the center of SGH campus. So if ever you find yourself there, go take a walk. It's just, in this beautiful lungs, right next to academia, block 7 of SGH. And all the more than 100 plants that are there, the majority have their genome already described. There's a little QR code for you to, look at the genome, look at the signatures. But we're going to learn so much more because we've done this, right? We need to do it. Somehow our colleagues in botany, they don't quite look at plants the way we do, which is what's the health impact. If you go to the rooftop of SGH, I just went there yesterday, it's all gardens. All of them, because of research in biodiversity medicine. We signed a collaboration with Brunei, looking at their biodiversity. But I think it's critical. We learned so much, and because of this paper, because of this study in Taiwan, we've taken it so much further. We're going to learn much more. And so, finally, I would say the benefits to our own people. We practice a different type of medicine now. We see patients with very high expectations. We deal with a lot of feedback from patients, and then we go out into global health. We engage with other countries. I think it's very fulfilling for our people as well. It keeps it real. It challenges us to push for better and better outcomes, and not just practice a somewhat polite social health relationship, that we sometimes have in Singapore. So it keeps us real. There are real problems that need real solutions, and we do need to keep pushing for better health outcomes. I agree with that. Health outcomes is what we should push for, not just equity and security. And we need to do it in a systematic way, not just in Singapore, but beyond. Thanks.
Thanks very much. That's a very great sharing about the kidney cancer in Taiwan, and also what you're doing in SingHealth. And Yijen and YY are on the exco of the Western healthcare cluster, and I'm sure they may be taking notes of what you're doing. But it does seem like SingHealth launches a center or institute every other week, which is quite impressive. Now,
Actually, it's been 5 weeks since we launched the last institute.
now let's move on to Vernon, who, as we mentioned, is the person razor focused on health security with the Communicable Disease Agency that's meant to make sure that the pandemics and outbreaks are mitigated in Singapore. And how do you think about health security in the lights of health equity, or that's not really going to be something that you are really concerned about?
I think the last one was probably a rhetorical question, right? No, I think health security certainly is at the top of our agenda and top of our minds. But I must say that memories are quite short, and so whether it was SARS and the aftermath of SARS, the 2009 flu pandemic, and many other outbreaks that we have seen, you can see that the memories of the world's political leaders, the financiers, and other stakeholders are extremely short. Even now, after the COVID pandemic, where there were a lot of promises for investment, for resources to be put into this, you can see that now some of those attention spans have been wavering to go to other areas. Not that those other areas are not important, but to actually address health security problems, you need sustained investment, sustained interest across a very long period of time. Because unlike anything else, health security threats and issues will definitely come. So it's not if, but when it will come. And if you look at the regularity or the increasing frequency at which new emerging diseases occur, I think the when is probably going to come more sooner rather than later. So I just wanted to touch on just 3 quick points. I think a lot of which Anders had brought up. One is that the world is a lot more connected now, and that's something that we really have to bear in mind. It's very interesting because we talked about globalization, and in fact, I still remember the first message and phone call that I got on this new Wuhan virus. Actually, I was in Switzerland. I was skiing with some ex-WHO colleagues of mine. So I was having this beautiful view of the Swiss Alps, and then my phone kept buzzing with messages, WhatsApps, and whatever it is, 31st of December, right? So there I was with this beautiful view of the Swiss Alps in front of me, talking about this new Wuhan virus. So what a way to have a holiday, right? And of course, instead of having countdown, I was texting my guys back in Singapore, which was New Year's Day, right? And we had to talk about setting up all these instruments and task forces and what have you. So the other thing I wanted to mention also is the concept of epidemiological distance. And I think in our local context, especially in the Singapore context where we are so interconnected, is perhaps equally as important as geographical distance. Because how we are connected to other countries and to other regions that are having outbreaks actually influences our local disease trends. So the COVID pandemic is a really good example again. I recall when you had the outbreak in Wuhan, China put in a lot of measures to try to curb the spread of disease. So although we had the odd case coming in from China from travelers, actually very soon Chinese travelers actually dried up. And we managed to control that very well for about a month or so. In fact, we went to 0 cases very quickly, and we were just keeping tabs on China and on other countries like South Korea, northern Italy that were reporting cases. So we were looking at where cases were being reported. And next thing, we had a whooping large outbreak in Singapore. And when we trace back where these cases came from, all around Europe. And where is the country that contributed most cases to us? The UK. Why the UK? Because we are most connected in terms of number of flights and travel to the UK. And a lot of students were also coming back from the UK for various reasons, for vacations or for fear of the virus, and they wanted to return to Singapore and so on. So this thing about epidemiological distance is very important. So we have to look at what are the stakeholders and partners where we are very connected with in terms of air, travel, trade, and so on, and collaborate with these partners. And this is actually as important as collaborating with people in the geographical region. Not saying the geographical region is not important, but all these other things need to be taken into consideration. So to build these connections, networks are then important. I think Anders brought up this thing about building those networks. Because calling a friend is very often more effective than going through the, what is that, diplomatic channels and all these official channels. Many instances I can give during COVID. One instance I'll give is South Africa. So we know that there was the Delta, there was the Omicron viruses that, the Beta and Omicron variants that were reported by South Africa. And of course, South Africa was very forthcoming in reporting all these new variants. But when we went through the official channels, you get very little information. You get official information, you can read in the newspapers, you can get information from WHO. You write in, you get those information, not sufficient for us to act. And fortunately, unfortunately, we do have air travel links with South Africa so that epidemiological distance is very short. And we know that we had to understand the situation so that we can do the right thing. And the right thing need not always be putting up border closures and all those things. We have to understand what does the disease actually mean in those contexts. So it was very useful that we had links from various people. I remember Prof Tan Chua Chuang, who's now the Permanent Secretary of NRF, had some links with his counterparts. I had some links with my counterparts from the work on influenza, which is my pet topic. Coronavirus happened to be another respiratory virus. So we called our friends and we got a lot more information than we had gotten from the official channels, helping us to provide that additional confidence that our policies were in the right direction. And it takes a lot of effort to build that goodwill and trust. Therefore, the setting up of the Communicable Diseases Agency and also the investment that the Ministry of Health and also other whole of government apparatus has been putting into building these connections has been in place before COVID, but certainly accelerating after COVID, because we want to build these connections. And all of these connections cannot just be built during a pandemic. You can't, during a pandemic, pick up the phone and call someone you have met maybe 10 years ago and say, oh, hi friend, hi bro, can I have some information? No one's going to provide you with anything, because I've had a lot of calls during the pandemic from people that I barely even recognize. But those friends that you meet every day, you dine with every day, less than $50, but you dine with every day. The Singaporeans will know what joke I'm making. But you dine with every day, you cultivate. These are the friends that you can rely on and will spend time to take you through these difficult times. So, and the final thing why we're also setting up this new agency is that the translation of scientific evidence to policy and clinical practice, the translation of policy to operations, and to be ready for the Future Disease Acts requires a lot of command, control, and coordination. You can't just bring people who you have not worked with before onto the table, suddenly expect them to work together. Therefore, you have to, again, in peacetime, bring all these people together to the table to be able to run through these scenarios, to be ready, to have all these exercises. And if you have a central platform to do this, it will make things a lot more efficient, so that when the button is pressed, you can be sure that everyone knows exactly what they need to do, and we can be better prepared and be ready to deal with anything that the world of diseases might throw us in the future. Thanks.
Thanks very much, Vernon. Now I'm sure you have made us feel much safer, and we hope that you will have undisturbed holidays during your tenure as the incoming CEO of the Communicable Disease Agency. But we have heard high-income country perspectives for the most part, and I think I would like to ask Kiesha to speak a little bit about her perspectives from the low and middle-income countries, because she spent a lot of time in Cambodia working with the governments, the NGOs, as well as the academic partners over there.
Thank you, Li Yang. I can talk about Cambodia, but also talking about Laos, I guess, to some extent, not very different. So reflecting on the lecture earlier, or the session that you presented, I think one key takeaway is the fact that issues around health is not only a health sector problem. I think it's really important and very pronounced in places like Laos and Cambodia, where if you think about the inequitable access to education, to infrastructure, and it just becomes, it tells you how difficult it is to actually ensure that you get everyone on the same level playing field. So we talked about, just before this session, actually, we had a meeting with YY, and in some places in Laos, you don't even get access to clean drinking water. So water being one of the SDG goals, talking about COVID and vaccines, that is a luxury, actually, if you tell me about it. So I think what we've seen with the pandemic is this inequitable access to just, health services, as you mentioned, and how it actually affects LMICs even more, because in Singapore and many high-income countries, the infrastructure already exists for you to just implement non-pharmaceutical interventions. If you think about working from home, home-based schooling, yes, it was very painful in the beginning and maybe continue to be quite painful, but we can do it. We all have access to internet, we have access to a computer. It may not be easy to get it at the last minute, but it's still possible for us to ensure that, every child in Singapore has access to a computer. But think about this in a setting like Laos and Cambodia, where not everyone has access to the infrastructure. It means if you close schools, you essentially prevent some form of education, but schools also serve as a platform for, the only meal that some children get. So closing schools just mean that you completely, remove access to food. So I think the concept in those kind of countries becomes more pronounced, especially during a pandemic. So I think one thing really also exciting when working in the low and middle income country setting is that they are able to do so much with frugal interventions, as what Ivy mentioned earlier. So having to redeploy whatever resources they have in order to actually get health outcomes out of it and to try to improve equity, I think is a learning point for the rest of the world. And I think we often need to humble ourselves to ask ourselves, okay, how can we also learn from our counterparts in low and middle income countries? So I think those were just my reflections.
Thanks very much for sharing that, Kiesha. I think those are important reflections and things for us to think about. Now, I know we are running short of time, but I'd like to open up to the floor now for your comments and questions. Yes.
Yeah, thank you. So I always believe that health somehow is always at the receiving end. It's the last thing. But there are many, many factors contributing to health, and it's very complex in a way how we can influence all these contributing factors towards having a better health. But I want to ask you these questions because I'm very fortunate, sir, to serve in the pandemic fund as a TAP member. And that also gave me the opportunity to open up a very small person from Singapore to a global scale to understand the global situations. So my question to you is that, from my perspective, I may be wrong, personal, that the WHO is certainly lack of funding. They're especially asking for donations to do multiple things, right? So pandemic fund is one of them. Global fund has been in establishments for a long period of time, and they're asking for emergency fund and asking for fundings. And I'm just thinking that at the end of it, if you look at your outcome, which is equitable health services and health and the security, who on earth, is it UN, WHO, or the government, G7, G20, who are the one responsible to look into all this, to me, in my mind, rather fragmented way of looking at things, and how do we put things together and make sure that it is something that is achievable? Because the way I look at it right now, like you say, 4 years, there's no progress.
And this?
Do I have another half an hour? To start with WHO, and then I can say a little bit about the international system or an organization more at large, because I agree with you, it's a very messy and complicated situation right now, and there's been a sort of an organic growth of new initiatives and new organizations. And again, a lot going back to an old agenda, and there's a need for radical reform of the system. So let me start with that then. To start with, we can close UNAIDS if we start by doing something more radical. We have today a number of different organizations then being about transfer of resources, money or commodities, Gavi and the Global Fund being the big ones. Then you have something called GFF, and now the Pandemic Fund. I think it was an absolutely crazy idea, creating a new fund. Instead of using what is there, instead of creating more, we should collapse, we should merge. And still being more smarter in terms of then, yes, there are certain countries that needs financial transfers, but fewer and fewer. The majority of the resources should come from domestic resources. But when it comes to access to commodities, to get the best prices, negotiating with the market, that's a function. And Gavi and the Global Fund are both doing that. Have one platform where you can have a marketplace and get best possible prices. I think one need to rethink the functions of the international system. You need an arena for political decisions, and that can be WHO or it could be the UN. then you need still to be able to generate new knowledge, technical guidelines, etc., the normative technical functions, WHO. But the financing, not WHO. And I'm deeply concerned also about WHO. Now I'm no longer with the government, so now I will say what I think. I'm deeply concerned about the WHO's involvement in the pandemic fund. Today, this is a source of financing of WHO. 60% of the funding goes to WHO out of the pandemic fund because of WHO controls the technical advisory group. That's a conflict of interest. I think it's really a bad setup. And WHO should not be about managing money. They don't have the competence to doing that. The third function here is, of course, then to support still countries that are in need of technical support in terms of technical advice. Again, WHO can play a role here, but in a different way than what they're doing today. Just to finish on then WHO's financing, they need more money. I don't think so. But they need different kinds of money. The money that they've got, so there are two problems with the money that they've got today, that the majority of the money are still earmarked. So they can't use the money for what the governing body has decided that the organization is going to do. That's the first problem. If they have total flexibility on their 5 to 6 billion, that would be enough money. That's not a problem. If they had that flexibility, they can also manage staff and having the right kind of competence and staff in the right place. Today, the staff is also very much linked to the funding. So you can't change staff. So the funding is not a matter of total volume. It's a matter of structure. And also, if you look at the last program budget, WHO is working on the 3 billion. UHC, universal health coverage, went up the budget 40%. Emergencies up with 40%. Health promotion down 4%. So it's also a matter of where the money is spent. And then the budget is there. If you look at WHO's financial reports, the planned budget for emergencies exceeds, it's 240%.
Yes. No.
So I wouldn't say that WHO hasn't got enough money. So please quote me on that.
Thank you.
Yeah, but I think one should make a distinction, and that's one of my big problems, that the pandemic fund is becoming a source of financing for WHO. I think you should make a distinction that we need a good WHO focusing on the normative technical quality work, full stop. WHO is today going into the business of providing procurement equipment, protective equipment. They want to supply vaccines, ambulances. Tedros was extremely proud at last executive board how many ambulances they have provided to Ukraine. That's not the work of WHO. So I think, and that's why I am concerned about also the pandemic fund is becoming part of the WHO architecture. And now also the negotiation on the pandemic treaty, there's also an idea about a new financing facility, another one. Will we have another one then? Why do we have another one? Who's going to control that? There's a need for some more radical thinking, talking, discussion, and decisions.
Thank you. I think those are insights that we would not get from someone who is not well versed with the WHO.
No longer with the government now. I'm an activist.
Now, we have time for one last question or comments. Anyone? If not, then yes. There are mics at the side if you.
Hi, Hui Lin, Associate Prof in the School of Public Health. So I think you get this question or comments a lot. Suppose when you talk to the finance minister and they say that the social determinants of health are more important to address than for me to put health up front in the agenda, how do you normally counter this kind of arguments?
Oh, that's a tough one.
I would love to meet that finance minister. I've never heard any finance minister saying that. Because that is what we need to do. So I would not counter that argument. I would love to see more resources on the social determinant, because that way it's what's going to have most impact on people's health.
Yeah, so I guess I have that question because you commented that health is not top on the G7, G20 agenda. Yeah. So there are probably other things that they think are a lot more important, and some of these might relate to social determinants of health. Then the question is whether we are capitalizing on their interests instead of pushing our own agenda. How can we actually navigate this differently? Yeah.
I think more of an issue in terms of financial priorities is that I mean, the appetite is more investment in the infrastructure, jobs, of course. I mean, there's a number of other priorities. And of course, today the climate agenda is also taking a lot of space, which is very important, very good also for health. But what is driving also financial decisions, and I was thinking about, Vernon, when you were saying about that we are quick to forget. It's very interesting, this psychology, that it's not just that we forget, but we just deliberately decide to forget. We don't want to remember. So when we ask politicians and people to talk about now we need to learn the lessons from the pandemic, they don't talk about it. I don't like it. I feel uncomfortable. So it's a very interesting psychology. Plus also that the psychology of why Minister of Finance, who should be good economists, don't see the economic argument to invest now instead of waiting and paying about thousands times as much when it hits next time. Why they don't make that economic calculation? I mean, it's very strange. But that has to do in some way. That's why I like the investment in the social determinants and the health promotion. That's really good value for money in the long term. But it's my experience is that's much more difficult.
Maybe if I can just add quickly to that as well. In fact, I do agree. I mean, if
And what do you think about WHO's financing?
no, I fully agree. I mean, a lot of the funds and staff are earmarked, and I think that's the major issue. I mean, having worked in WHO, it's nice if your program is well funded, but then for some other program that's not as well funded, excess money cannot easily be transferred, and so a lot of that creates this problem of being able to quickly respond. And I also agree on the comment that WHO's main task, which you have also described in terms of timelines and so on, is actually to provide good international guidance to member states. Some countries may have their own mechanisms to do that, and so they do. Like in Singapore, for example, we stood down a lot of measures and we went towards declaring the end of the pandemic before WHO did. We have the mechanism to do that. A lot of countries don't. They rely on WHO's assessment, and WHO should be more forthright in putting out those assessments. But okay, that's WHO. But back to this finance issue, I think the question is, how do we work together with the powers that be, whether ministers of finance or governments and so on? Because the minister of finance is only minister of finance because someone put that person there. In some countries, it might be the people because that person has to stand for election. In other countries, it might be the president. So that individual has certain interests. So we need to find out what and how do we align that individual's or that government's interests with ours as health and public health professionals. Because if we start barking up the wrong tree or banging on the wrong table, nothing's going to happen. Unfortunately, in many governments, the people in power tend to only stay there for a very short period of time. So there's always this inclination to want to do things with faster delivery timelines. And unfortunately, when we talk about, say, health security, pandemic preparedness, there was a paper that was just looking at saying that the risk of a pandemic or disease X happening per year is about 2%. 2% per year. 2% per year, in my books, I'm not sure, I mean, Alex is the expert here, is extremely high, which means that in my lifetime, I'm going to see a pandemic of equal or higher severity than COVID-19. However, in a politician's mind, if they're only going to be re-elected for the next 5 years, I might take that risk because 2% a year in over 5 years might not be as high. So I think I'm not saying that that's not important. I'm saying that we need to look at how to align our common interests, which is probably a different topic for another time.
Just to say on, I mean, your president is obviously not having so much of power, but Tarman, when he was leading the G20 panel, parallel to our panel on financing, I mean, their report was very good.
Yeah.
So if we implement that, that would be brilliant.
Okay, Ivy.
I mean, the government system in Singapore is a little different, so maybe there's a longevity. But I am no expert in that. I think Ivy might have this.
No, I just wanted to say social determinants of health are clearly critical. And I think, you were talking about clean water. There's no point talking about vaccines if you have no access to clean water. And I would say it's a recognition of that our whole campaign on Healthier SG, actually, it's based on that the hospitals cannot just be within the walls of the hospital, but you have to go out there. And I think Ejan and all know it. We've done the same. Look at the rental flats. Look at the migrant workers in Singapore. the factors that determine their health in peacetime as well as during pandemic time is based on all these things. You know, how many people do you sleep with, you know, in a room? How is the ventilation of that room, etc. And so increasingly, we need to focus on that. Yeah, thanks.
Thank you. Okay, Vernon, hopefully when you go to the Ministry of Finance with the CDA budget, they won't talk to you about the social determinants of health. But with that, we have to come to a close, and I apologize for running over time, but I think we have had a very good discussion. So thank you very much, and please show your appreciation to the panel.